All right, well, it's another month, another eJournal. I'm here with Chris Griffith. He's a senior article on the journal we're discussing today. Chris is a co-worker of mine. How was the trip in? Good?
It was good.
Yeah.
Two flights of stairs.
Two flights of stairs. So he made it. Okay. So anyway, so the journal today, or the article today, is high-risk human papillomavirus testing in cytology, aspirate samples from head and neck. Part 2, a survey of the American Society of Cytopathology community. Okay. So here's a picture of me. I'm assistant professor. Here's a picture of our gorgeous campus. This is Chris Griffith. He's an MD PhD. He's the associate professor here. He's also the director of head and neck and surgical pathology. And he's also a cytopathologist. So today we're going to review the HPV testing and evaluation of squamous cell carcinoma of unknown origin, especially in the scenario of metastatic to the cervical lymph nodes. Then we're going to focus on the survey that focused on 3 main topic areas, and we'll go into those as we go along. And then I want to discuss a little bit about the role of HPV testing in these FNA samples in lymph nodes, cervical lymph nodes, what that looks like in the future. So a little bit of background, testing for high-risk HPV virus status in head and neck carcinomas has a role in both diagnosis and prognosis, and accurate preoperative diagnosis is crucial for appropriate clinical management. So high-risk HPV positive oropharyngeal squamous cell carcinomas is a distinct clinical pathologic entity. As many of you well know, their patients tend to be younger. They tend to be former or non-smokers, male, but these patients overall have a better prognosis and response to therapy. These high-risk associated oropharyngeal squamous cell carcinomas tend to have a smaller primary tumor and a bulky metastasis. And the reason that that's important is because it's often very difficult to find the primary tumor, and the patients generally first present with these bulky metastases, usually in the cervical lymph nodes. So do you want to tell us a little bit about these ASCO guidelines?
So yeah, I mean, one of the important things about HPV-associated oropharyngeal cancer is that's really a distinct tumor. It's totally different than HPV-negative squamous cell carcinomas. And so CAP, started with the WHO, but then also CAP and ASCO have created as a distinct entity. So CAP and ASCO, though, have put out guidelines that are focused on the appropriate testing for these specimens and how to determine accurately if they are HPV positive. So they put out guidelines as to what specimens should be tested, which include known oropharyngeal primaries, but also carcinomas of unknown primary in the neck, and then also how to test them. So CAP talks about using P16 IHC as a surrogate marker in both the primary sites as well as in the neck nodes, and ASCO similarly said the same thing, but ASCO did prefer using direct HPV testing in metastatic sites, including the neck and level 2 and 3.
Okay, so I got a little distracted getting the microphone. So ASCO prefers direct.
Yeah, so ASCO prefers direct testing in the unknown primary setting. And that's just because even though P16 has such a high positive predictive value for HPV, when it's an oropharynx, that positive predictive value does drop off a little bit when you're dealing with a met of unknown primary in the neck, although it's still very high, above 90%. And that's why CAP is okay with it.
Can you expand a little bit on specific testing? What do you mean by that?
So that would be just specific test to detect the actual HPV genome and show that it's transcriptionally active. So the most common test we use clinically would be in situ hybridization. More recently, people are using RNA in situ hybridization for E6 and E7, but also assays that look for the HPV DNA, by molecular methods, and then we have liquid-based cytology testing that we use in cervical vaginal would be another method.
So essentially, there's a wide array of methods to test for HPV. Some are via surrogate markers, P16 using IHC, and which is likely the most common, but we'll get into that. Other are these specific modalities which differ greatly from institution to institution. So as mentioned, although CAP guidelines allow for P16 IHC alone in this setting, ASCO guidelines favor HPV specific testing, which is what we mentioned is either ISH and situ hybridization or molecular testing. Of note, these guidelines have limited recommendations regarding the interpretation of P16 immunohistochemistry or the preferred HPV specific methods of testing for aspirate samples. So not only is it unclear, which one should you use, but even the guidelines within the different types of testing is unclear. So for P16, what is the limit, the threshold limit, and then which types of HPV specific testing, which you just talked to. So the CAP does highlight the need for laboratories, so the need for laboratories to do independently validated testing methods to suggest P16 IHC thresholds. So, so they're saying that the thresholds may vary based on your validation. Is that right?
Yeah, that's correct. So on the cytology samples, the lab should really do this testing themselves and see what is best at predicting HPV status. On histology, it's very standard that P16 with 70% strong diffuse, like block-like staining, counts as a surrogate marker, but that is not as clear on cytology.
Very good. So to better understand the state of high-risk HPV testing in these head and neck specimens, and as a step to creating a better consensus, you and your group surveyed the American Society of Cytopathology members regarding their current practices. The survey focused on current methods for collecting and submitting specimens for HPV testing methodologies, test validation, interpretation. So one question I have is, how did this all come about?
Yeah, so I was lucky enough to be on the clinical practice committee for a couple of years, and I think it was a really great setting because a lot of us on the committee the last couple of years actually had a focus on head and neck and obviously cyto, and so we all saw a lot of these specimens and shared this concern that there is a lot of challenges in determining HPV status on cytology specimens, and so as a group we agreed that some more guidance and understanding of the current situation would be helpful. So we had a great group, and I was lucky enough to work with everybody else on this paper as well. It was a bigger group actually. This is just a subset. And so we were able to put this together, and hopefully it has a lot of useful information.
Yeah, so tell me a little bit more about, so this is part 2, and you alluded to part 1. Yeah, tell me more about part 1.
Yeah, part 1 is just a review. So the review article goes through a bunch of us just, spend a lot of time going into the literature and reviewing what different assays are available and what data has shown and how effective they are in different specimen types. And so part 1 is just a good overview as to, what options are out there. And then, part 2 is this survey, which is really just to establish like what's the current status and maybe think about how we can move forward from here.
So a little bit more about part 1, even though this is not the paper, were there any interesting findings that you can remember?
I think, and it comes out in the survey too, but there's a lot of nobody knows the right answer for how, what's the threshold for P16 on cytology. There's a lot of variables that go into it. And in the literature, there's a lot of variable thresholds that articles have suggested for different P16 thresholds. A lot of that's going to come down to lab specific techniques that are influencing that though.
Okay, so we'll go to the survey. So the survey tested or asked about the specimens, the methodology, they ask about validation, and then interpretation. So what did you expect to find?
So I think, we expected that a lot of labs would be using P16. It's just the most available. And then, I was curious, but I had a lot of questions. I'm a real big proponent of using liquid-based cytology testing like we use in cervical vaginal. And I was curious just to see, I know some other labs are doing this, just, in talking with other colleagues. And so I was curious to see how common that was. And then, the other question was, knowing our own internal challenges here and other institutions I've been with determining this, HPV status on cytology samples, I was curious to see if other laboratories and other pathologists were having the same issues.
Did you expect anyone to be using like the same machinery that they use for the cervical?
Oh yeah, so I would expect that so when you're talking about liquid-based assays, the expectation would be that, yes, if you're using it for your cervical vaginal pap specimens, you would use the same exact assay, because in many of these cases, you could collect your FNA aspirates into the same exact media.
Very good. So as you just mentioned, it was the ASC Clinical Practice Committee that you served on that surveyed these people to determine the current methods in use for this high-risk HPV testing for head and neck specimens. The survey was created by this Clinical Practice Committee work group and included a wide array of different positions, including cytopathologist, cytotechnologist, and it was ultimately approved by the ASC Executive Board. So the title was P16H papillomavirus, human papillomavirus testing in fine needle. It was administered using SurveyMonkey. Survey consisted of 28 multiple choice questions and 1 request for comment. How'd you choose the questions? Who chose them?
Yeah, so we worked out the questions as a group. We had multiple meetings ahead of time just to talk about, what topics we wanted to ask about. It's a complex survey because depending on answers to certain choices, you may be prompted with different questions. So it was complex working out the details of how it would flow through. And then seeing it in practice, it worked pretty well, but there were a few inconsistencies in the data which do get discussed in the paper. I think with a complex survey, that's probably always going to be the case. And so yeah, we knew what concerns we had and what our thoughts were, and so we kind of based the survey to try to get that data out of the ASC community.
Were you a little concerned about it going to the ASC community in large, and that you were going to only capture essentially academic institutions?
I mean, we know that going into it, that is a concern, but I don't really know how else we would do it.
Yeah.
I think one of the other concerns is that we don't have one answer per institution, so we don't know, how many of these answers came from the same institution.
Right.
But again, that's very difficult to control in this type of survey. And there's solutions to that, but this was, probably the easiest and most effective that we could come up with at the time.
And then, how did it get distributed to the ASC members? Was it done just via email or?
Yep. So just via email, the listserv for ASC members. So I know I got lots of emails about it.
Yeah.
I appreciate everybody who took this time to fill out the survey, because I know we all get a lot of surveys. But I think this one provided a lot of useful information. So I appreciate everybody who helped put it together and who answered the survey.
And just because I'm curious, how many respondents did you expect?
How many did we expect?
Yeah, I know how many you got.
Yeah, I don't know how many I was expecting. A couple hundred would have been good, and
yeah,
we got 277, I think, so somewhere around there. So I think we got a good response. I don't know how many emails are on the ASC listserv or how many members there are, but
yeah,
it seems like a pretty good.
That's a pretty good, it's a pretty good response. All right, so yeah, so as he mentioned, it was a complicated survey, and so the last bullet point says it was constructed to allow the respondents to answer some or all the questions based on other responses. So, so interesting. So as you mentioned, complex survey. So many questions included a free text option, and some allowed for multiple responses. But you essentially want to divide it into 3 main groups. And so the first group was practicing HPV testing of aspirate. So a survey, ASC community 307 background information on respondents. So you want background information, the level of service or current practice for collecting and submitting specimens for HPV testing. So how are they getting these samples? Yeah. Is it cytopathologists, cytotechnologists? Is it the clinicians? Because we're talking about head and neck samples and FNA, that means someone has to perform the FNA. Is there rows, etc. And then this idea of validation. So as we mentioned, CAP, says, they suggest that you should validate these samples, and then the validation, especially for the P16, is based on your percent cutoff is based on your validation, but I believe 70 is generally what is expected. So the survey went from March 11th through April 30th. They were given 50 days to respond. 277, as you mentioned, but not everyone responded to every question. And so let's talk about what you guys found. So the majority of the respondents are at an academic medical center, and so that's something that we talked about, that because it's ASC, there's largely an academic institution, but obviously not exclusively, about 70% or from an academic center. But I still think you guys got a pretty good number from community hospitals and private practices. So about 25% of 69 respondents. 13 were at a commercial reference laboratory, and 3 were at a Veteran Affairs hospital. So pretty good distribution, but obviously weighing to the academics. So you want to talk a little bit about figure 1?
So yeah, so this was just to get an idea of how busy a lot of these practices were, and you can see, a large number of the practices had, a majority of the practices that responded, or the respondents worked at a lab that had over 5,000 non-GYN specimens. So that just shows this here. Only about a third of them had less than 5,000 non-GYN specimens per year. So pretty busy practices.
Do you know how many we do here?
I don't. But
it's got to be a lot. I wonder how many do I by myself. So the survey respondents, 188 of the 272, so 69% were cytopathologists, but a good number of cytotechnologists, which I think is great. Residents and fellows did participate, 14, and then the remainder included a potpourri of research scientists, laboratory managers, and laboratory directors. Okay, so do you want to talk a little bit about implementation rates?
So I think right away you can see, it's good. A lot of laboratories were offering this testing. So 80%, at least offered some type of HPV testing or had the ability to send that testing out. So that right away is pretty good. And this is one of the early questions where if you didn't perform it or do a lot of it, it jumped you right to questions as to, maybe why not, and you wouldn't have to deal with a lot of details about the testing. So the fact that 80%, there's still obviously labs out there that don't offer any type of testing. So that's one thing, so that was 39, about 14%, didn't even offer it or even sending it out. So that, we then wanted to really dive into that group as to, why are they not offering it? What are the reasons behind that? Because that was one of the questions we had. I think I was actually surprised to see how many labs have it. Luckily, P16 is highly available in most labs, so it's good to see a lot of labs were doing some type of testing.
Okay. And do you want to talk about so this is the barrier. So these are the people who didn't offer that 20%.
Yeah, so this is that small group, the 14% that said that they did not offer it, even as a send out. So we wanted to see what's the reason. So the biggest reason was that they just didn't have enough specimens to allow validation. It may mean that they don't even have any specimens and they have no interest, but there's also an issue where you may get an occasional specimen that this testing is important, but because you have so few, you can't even, mount the validation efforts to really allow the testing, which would be unfortunate for those, those few patients that do get that testing done, and have a metastatic squamous cell carcinoma in the neck. And then part of it's also, lack of clinical demand, which goes along with a lot of that. I think in pathology, we are, for the most part, very well aware of HPV and its importance now in head and neck, but I think there's still a lot of clinicians, especially in the community, that may not be as aware of the importance of it even. So that could be why there's some lack of clinical demand.
And I think, this might be a good opportunity since, you do run our surgical pathology, head and neck department here, and you're a cytopathologist, to talk a little bit, about HPV related squamous cell carcinomas and the importance of testing for it.
So yeah, I mean, it's obviously increasing incidence of HPV associated head and neck cancers. I mean, first of all, we're learning how many more are HPV associated, but the one thing that's for sure is in the oropharynx, it has a very important prognostic significance. In the past, when patients were treated just like any other head and neck cancer, if you had an oropharyngeal squamous cell carcinoma, you would get very aggressive surgery and chemoradiation, and really the side effects of that can be pretty horrible for those patients. And so now that we know that HPV is less aggressive and responds better to therapy, there's a lot of clinical trials looking at de-escalation of therapy. So there's trials that look at surgery only for selected patients or chemoradiation only to spare them one of those other modalities. And that results in a better functionality for those patients later on, but we still have to figure out a way to treat the patient, so we need to know if they're HPV positive so they can be eligible for those potential trials. But then also now there's a lot of work looking at who should we de-escalate and who should we not de-escalate because they need more therapy.
Right, so within that cohort of HPV positive patients, and so like what what factors would affect whether or not to escalate or de-escalate? I'm assuming T stage, like size.
Yeah, so size, the number of lymph nodes. Well, we don't use extranodal extension to stage HPV positive. It still is incorporated in the clinical stage, and a lot of imaging still looks at that question. That would be one thing trials would look at. Smoking status, so people who smoke more, they have worse outcomes. And then there's also a lot of new data that's looking at, nuclear pleomorphism and anaplasia, and different factors, and then also different mutations in these tumors that are potentially important.
So that smoking is kind of interesting to me, because if this is HPV associated oropharyngeal squamous cell carcinoma, you would imagine that the driver is the oncogenic nature of the HPV virus. So tell me, so is it just like correlation?
Yeah, so that is, HPV is obviously the driver for these patients, but being a smoker doesn't protect you from HPV associated oropharyngeal cancer. So you can still get it. It probably still has some etiologic role, just like with cervical cancers. Smoking is an important risk factor. And there's just definite data that the more smoking history you have, or if you're a current smoker, you perform worse and your tumors respond less well. Even in conventional head and neck squamous cell carcinomas that are not HPV associated, to continue to smoke greatly decreases your prognosis. So smoking is just a negative prognostic factor for all head and neck cancers, really.
And so, obviously you can't predict the future, but you mentioned surgery only, you mentioned chemo, radiation only. Where do you see, let's say the patient's got a small oropharyngeal HPV associated squamous cell carcinoma. Do you think it's possible that they could not get those? So for those who don't know, a lot of the head and neck surgeries for squamous cell carcinomas are, as you mentioned, they have a high morbidity. Do you think there'll ever be a point where they don't cut out the tumor?
Yeah, so actually here at Cleveland Clinic, a lot of the effort is looking at more chemoradiation for these patients. So we actually do not see a lot of resections for oropharyngeal, HPV positive oropharyngeal cancers here. We mostly get resections when it's recurrent at that point. Whereas where I worked before at Emory Clinic, they actually did a lot more primary surgical resections. So they were doing TORS, so transoral robotic surgery to excise primary tumors, and then they would do a neck dissection. And then if after the pathology is analyzed, they meet certain criteria, so like negative margins, low risk factors, those patients would then just be watched on a clinical trial. And so, a lot of these trials are going to be great, and it's going to be good to see which one of these techniques is the best and which factors matter the most for these patients.
Yeah, and I think ultimately this discussion it really demonstrates the importance of, and why CAP is so adamant, and all these other agencies are so adamant about performing some type of HPV testing, whether it's P16 or HPV specific testing, because clearly the range of options is quite different than that of the traditional squamous cell carcinoma patient. Yeah. Okay, and the traditional squamous cell carcinoma patients, they tend to recur. I feel like
head and neck,
it's a field of like a field effect. Yeah.
Yeah, head and neck squamous cell carcinomas are very poor prognosis in general. Yeah.
Okay. So back to the survey. So specimen collection and triage for HPV testing. So 138 at 210, which is 65%, indicated that the cytologist performed the FNA procedure or provided a rapid on-site eval. So in the majority of the cases, the cytologist was present, at least present, if not performing the procedure. 62 of the 210 responded that clinicians performed the FNA without the rapid on-site eval. So 2/3 basically cytologists there, 1/3 not. But it didn't. But regardless of performed the procedure, the reflex testing for HPV was performed by 91.4%. Now, were you surprised by that number? Were you motivated by that number? Did you think it was a good thing?
So I think, so this means it's reflexively done. So, if you, as a pathologist, you get a specimen that you can see the patient has either a suspected oropharyngeal primary, or the neck node you're looking at is carcinoma, a squamous cell carcinoma, and there's no obvious primary. So I think it's great that there's such a high rate of reflexive testing, because really, the testing needs to be done. There's plenty of guidelines that say it should be done. So I was actually pretty happy to see such a high rate of reflexive testing, and I would say it was probably higher than I expected. But then you can also see in your next point, half of the labs also allowed requests to come in for clinicians, which is great because sometimes, you know, on our end, we may not realize that we may, you know, not see all the data that the clinicians are aware of, and we may not test all the cases. And obviously, a lot of labs will allow the clinicians to request. So, so I thought that was really reassuring, and I'm glad to see that so many labs are doing reflexive testing for most of these cases.
All right. So the survey shows that the FNA of the cervical lymph nodes is the most common specimen. Though the majority of the respondents tested the material from any cervical lymph node involved by squamous cell carcinoma, 83 of the 203 limited testing to the upper lateral node. So can you kind of explain why this is important in your paper?
So I think as a group on the committee, we were kind of curious, you know, because the guidelines are specific to known oropharyngeal or metastatic carcinoma, squamous cell carcinoma of unknown primary to level 2 or 3 in the neck, just because those are the sites that are most common for oropharyngeal. So I think that we were just kind of curious, like, are people really sticking to these guidelines strictly? Are they kind of going outside them and testing more? You know, and also, I mean, if you don't know the neck level that is the source of the unknown primary, you should also be testing. So we were trying to figure out how to kind of tease out some of that info here and see, you know, how strictly people were following that guideline. And I think it's actually a little bit hard to tell still, but, you know, clearly a lot of labs are testing any metastatic squamous cell carcinoma in the neck of unknown primary, regardless of neck level. And I think that's probably not a bad idea, so I think it's good. You do have to be a little bit careful because once you're outside of level 2, 3, you have a higher rate of non-oropharyngeal carcinomas metastatic those sites. And so P16 may, you know, positive predictive value could drop even further there. So you just have to kind of keep that in mind. The lucky thing is that, you know, a lot of other sites are not likely to lead to unknown primary with a met to the neck as highly as oropharynx though. So.
Right. So so the guidelines are HPV testing on levels 2 and 3, which are upper.
Yeah.
And do they say anything about the other levels? They say don't do it.
So so they don't say don't do it. They just,
okay.
It's not part of what they are saying you should do. But I mean, I think it is important to remember it's all based on statistics and, you know, what's the most likely thing. And so when you're in level 2, 3, you know, you're likely to be an oropharyngeal primary.
Right. So that's the idea of positive predictive value. It goes up when the population is more likely to have a positive result, which is why they want you to do it on that. Yeah. Okay. So what else we have? So in the presence of known HPV-associated squamous cell carcinoma, 129 of your 203 perform HPV testing to confirm at sites to confirm metastasis. So this is saying you're using it as like diagnostics?
Well, to confirm that it's from the unknown primary. So that's the one thing the CAP says, you know, it's optional. You don't have to test. So if you have a patient that you know has an HPV-associated oropharyngeal tumor and they have a metastasis, you know, they would kind of leave it up to the clinicians and the pathologists to decide, do we need testing in this case, or can we be, how sure are we that this is a met from the oropharynx? So obviously, if you show it's HPV positive, you're quite sure it's from the oropharynx in those patients. And so I think it's probably what I would expect, that a lot of people are testing these mets still just to confirm. You know, some of these patients may be smokers still, so, you know, you could be getting a primary lung cancer and those can be basaloid. So, you know, it still is frequently a question, can you confirm that this is a met from the oropharynx? And so a lot of labs are doing that testing. You know, we test it pretty regularly here. I'm sure some of us do it reflexively, and then others do it kind of when the clinicians are worried, or we talk to the clinicians to say how likely or how concerned are you about a met versus a new primary.
Yeah, that clinical information is always helpful. Then in the last point here, you say interesting is small percentage, so it's 37 to 203 performed the P16 high-risk HPV testing on specimens from distant sites without a history of HPV-associated squamous cell carcinoma. Why is that interesting?
So, I mean, it's interesting because you're kind of just taking a shot in the dark that even though there's no history, you may find that this is HPV positive.
Right. You might be over testing at that point.
Yeah, right? So I guess I'd be curious to know how often somebody finds that HPV positive tumor in a patient with no known history in distant metastatic sites. I would imagine it's not often.
Right, you would think that they would have some cervical lymphadenopathy prior to distant metastasis, which would have revealed itself.
I mean, yeah, and it would also pick up HPV positive tumors of other sites, cervical cancers.
That's true, so it's not necessarily specific. Great. Okay, so the most common test performed, probably, were you surprised by this, IHC?
No, not
Yeah.
at all. So yeah, P16 is, the cheapest and most available. So, I would expect that to be the most common test used.
Yeah, and so it was performed. So one of the questions we did this Twitter thing last night was, do you have to do it on cell blocks, or biopsies okay for the guidelines?
So,
And obviously,
so I was actually on a committee years ago
okay.
Through the American Association of Otolaryngology, head and neck surgery, and in that committee, we were actually trying to address that a lot of these HPV positive patients were going undiagnosed for longer periods of time, and a lot of times they weren't getting an FNA because a lot of these patients present, it looks like it could be an infectious disease, inflammatory disease, because they're younger, they're not smokers, so clinicians aren't as aware. So that committee was really focused on making sure clinicians are aware of the importance and the possibility of this disease and not delay diagnosis. And in those guidelines, we recommended that really the preferred testing method would be an FNA.
FNA, okay.
Core biopsy is okay, and we certainly get some here, but there is, it's a little bit more invasive, and FNA really does work really well in these cases, especially if you have the right testing methods set up. And so we really were focusing on FNA. We did ask about if people were doing testing on core biopsies, and people do it on core biopsies also. I'm sure a lot of labs get a mixture of these depending on the clinician or radiologist preference between FNA and core.
Yeah, so I mean, and then I just from a cytologist point of view, thought this last thing was interesting because my first experience with a cytolite cell block was here. I always used formalin before, but looks like it's about 50-50 between formalin and cytolite, with the edge going slightly to formalin, and then some other solutions, this non-fixative buffered solutions such as Roswell Park Memorial Institute or phosphate buffered saline. I'm not aware of those.
Yeah, so I think those are just a collection media that my guess is labs have clinicians collecting that just in case they want to do flow cytometry.
Oh, okay, yeah, okay, I see. Okay, yeah, I understand what you're saying. Okay, great. And then SurePath, 15. Okay, so this is a little bit, do you want to talk about this at all, or?
So this is just looking at the different cell blocks. So I mean, I think one thing out of the survey.
Validated.
Oh, no, that's the next one.
Okay.
Oh, this has a combination.
Okay.
There's a lot going on this table. So we did, I think one thing that the survey did show though is that there's a wide variety of both fixatives and cell block preparation methods, which really gets to the point that each lab really needs to validate their own system and the path that they take to prepare, the cell blocks in these cases and see how that works with their P16. Another part of this is to look at, how often were they actually validating on the different cell blocks, and you can see it's pretty variable. I think the next table might even be a little bit more interesting looking at that, but within, it was variable even within different cell block methods that people were using, if they had validated it and what their thresholds were. But one common thing is always that 70% tends to be a very common threshold. You can see from this in that right-hand part of the table, the threshold bucket section, that there was a little bit more evenly distributed threshold level in those non-formalin fixed type cell block techniques.
Yeah.
Which does suggest that, those other techniques probably result in lower antigenicity for P16.
Interesting. Okay. Well, to talk a little bit more about validations. So for the validation threshold for IHC on cell blocks, there was a plurality, 44.6%, so 79 indicated that there was a formal validation performed. 67 of 177 indicated that the formal validation of P16 on the cell blocks was not performed, and another 31 were unsure about the validation status of the P16 on cell blocks. You want to speak to that?
Yeah, so I think this is maybe one of the bigger and more important parts about this whole survey. I think it's not unexpected that there's still a lot of labs that have not validated it. It's a little disappointing to see because it is important, but it is not unexpected, and it's also understandable why so many labs haven't, because there are a lot of challenges with validating. So we didn't ask. I think one of the things that I would have loved to have known is specifically the labs that haven't validated but are using it, what were their barriers to validation? Because I think that's probably a good area that we still don't know the exact answer, but it probably mimics, probably
is similar to some of the reasons why the labs that haven't even validated at all or aren't even using it.
And then, just real quickly, can you, we have a wide range audience here. Can you talk a little bit about what validation is and what needs to be done by a lab to validate an antibody?
Well, for this, this is not just where you're asking, should it be positive or negative, but actually does it correlate with HPV? So I think the validation for this is a little bit different. I think, and it's still going to be up to each lab to figure out their best way, but in the end, you need to decide on, for this type of a test, you'd have to decide on your gold standard for what is an HPV positive tumor. So you have several options there. You could have known oropharynx with, a direct HPV test, or you could have known oropharynx with P16 positivity. You could use a combination. You could use different HPV testing methods as your gold standard, either, something else that's already been validated and that is accurate. So those are the things that you have to have as your gold standard. But then from your cytology side, you have to just do your technique that you would do if it's P16 on your particular cell block, and then probably document what percentage of cells are staining and how do those correlate with HPV status on your gold standard. You could even do things like receiver operator characteristic curves to decide what threshold you should use for considering it a positive HPV result. Some of the papers in literature go down to 1% P16. I think that's a little bit concerning because then you're starting to have the risk of false positive results. So I think you have to have a balance between sensitivity and specificity with whatever threshold you use, and at least know what your risk of false positive and false negatives are for HPV status.
Right. So no test is perfect, but there is a gold standard, and the idea of validation is comparing, a known sample with that has gold standard, positive or negative test, and then comparing your new online assay that you want to upload and make sure that it's working essentially. And so and that sounds like kind of easy, but it's not, because you have to get the known samples, you have to accrue them, then someone's got to cut them, and then you got to do the stains, and this is all before you even use the thing. So validation is difficult. There are we have whole teams that are always validating any new antibody in our surgical pathology lab. I know that not every one of our we use Cytology here, so we have to validate all of our formalin fixed or all of our antibodies that are validated on formalin fixed. We have to revalidate them on Cytology, and we have a lot that have been validated, but not all. And I think that's due to kind of the time and labor intensive nature of it. And so I guess I'm not entirely surprised that some people have not, Okay.
I will say, even if it's not, I would recommend any lab at least look at the data of what they have so far. So even if they don't do a formal validation, look at your past cases to see what correlates with HPV positivity, and at least as a group come up with a threshold that you think you should be using.
Right.
16 on cell blocks if that's your testing method.
Right. And so kind of on that note about the threshold, so in general, the threshold for P16 IHC is about 70%, but that will change based on your validation. And so do you want to make a comment on the last
yeah, so
here?
70% was still the most common in this survey. And so, some of those people said they did validate, some didn't. But it was interesting that according to the survey, whether the respondents said they validated or not, they both had a wide range of what was considered positive. So it's not clear, how are labs deciding on their threshold if they're not validating?
We have a table to show that here, yeah.
So you can see whether they said that they validated or not, it was a fairly even distribution. So it's just, in the non-validated ones, it's curious as to know how they decided on the threshold.
Right, and so you can see, so the threshold percentage of P16 positive is on the left, and then the cutoff is the numbers. So formally validated, that's the number of labs that cut it off. And so the formally validated was 19 versus 22, but what he's saying is there's a distribution among that mean, where even in the labs that formally validated, you still have a lot of people at 1%, 10%, 15%.
Yeah, exactly. Yeah, it's a very similar distribution between labs, or respondents at least, that said they validated and didn't.
In response to the questions regarding handling of cases with equivocal P16 or cytomorphology and P16 IHC status for discordant, An almost equal percentage of respondents reported reflex, as we mentioned, to ISH, which is specific. Those that recommended P16 IHC testing on subsequent tissue resection. So 86 to 82.
Yeah. So yeah, I mean, there's negative P16 obviously, and then but there's a range in between. A lot of people think, at least using histologic criteria, between 50 and 70%, or maybe there's something funny about the staining. Maybe it's only cytoplasmic or only nuclear. It doesn't really fit what you need for positive, but you're wondering if it could be an HPV positive tumor. That's what we would consider indeterminate. So those patients obviously need additional testing, whether it's on the same specimen or another specimen that comes later. Even the CAP guidelines say that in patients with known oropharyngeal primaries, if you have negative P16 testing on a cytology sample or a small biopsy, you should repeat that on the resection just to make sure you didn't have a false negative on a smaller sample.
Great. So now we're going to the specific testing. So it's for high-risk HPV. So it was performed on in-house or sent out by most respondents, so 139 of 193, so 72%, who were approximately even split between in-house and send out. 54 of the 176 did not offer testing. For those laboratories that offered ISH, it is performed almost exclusively on cell blocks and core biopsies. And formal validation of HPV ISH is reported more frequently than validation of P16 IHC. There's a lot to talk about there.
Yeah, so I think the important things, obviously ISH is becoming more available in a lot of labs. So you can see a lot of labs had it available. Again, this was biased towards academic centers and probably larger labs, so that explains a lot of that. A lot of labs are doing it on cell blocks and core biopsies, which makes sense. So there's rare, reports in people that do ISH on aspirate smears, which is fine if you validate it. And then the formal validation of ISH, I think if you're doing this on cell blocks, you should have some type of validation specifically for your cell blocks. I wonder how many of these respondents are actually just talking about the fact that they validated the ISH at all in their lab and not necessarily on, their cell blocks. But I think that would be another thing to make sure is working properly on your cell blocks.
And then what do we do here?
At this point, we do a lot of send out for liquid-based testing on our cytology samples.
Wow, that's a great segue. So liquid-based testing and cytology samples, what do you think about that?
So as I've already said, I'm a big proponent of this. I think there's a lot of benefits to the liquid-based testing. It works really well on cellular aspirates that are swam, but it also works really well on the cystic and degenerated aspirates that we all know are going to be very difficult to test by P16 or ISH on a cell block because you just don't have a lot of viable cells. So this is a very good, because you have a lot of cell-free DNA in those specimens that can still be picked up. A lot of labs already have liquid-based testing assays available because of the cervical vaginal samples. And really it's a very similar process from, the only thing that's different is cervical vaginal, you're using a brush, you're going to pick up a lot of benign, non-HPV infected cells, whereas with the HPV mets to the neck, you're getting almost pure population of HPV positive tumor cells, if that's what it is, in your solution. And so it actually is a very sensitive test. And I think if you can validate this, it's probably the best way to go in your lab. Because I just think it has a lot of benefits and it's available. But I think there are still some concerns about how to validate it, which I can go into if you'd like.
Yeah, we have time.
So, one of the questions is what, again, you have to figure out your gold standard, just like you would have to do your P16. There are other, I know some labs have done this validation just by, they say they need so many positive and so many negative cases, and they do the testing. We've run into more challenges here because in our lab, it's been decided that we need to do limit of detection for each of the HPV types. And so, that's been a lot harder for us to validate using that stringency of validation. And so that's one of the reasons why we still send the test out here. I found another lab with some colleagues that has validated their liquid-based assay on SurePath, which is what we use here for neck aspirates. And they validate it internally, and so we send samples there. I do think it's also a good test because it's actually pretty cheap, honestly. It's more than P16 IHC, but it's actually a lot cheaper than the billing for in situ hybridization. I think the billing for this is, around $100. I think it's less than $200, whereas ISH testing is often billed around $800. So, you know, I don't know how much you get recuperated in any of that, but that's the billing that I'm aware of for our area. So it's actually a cheaper test. It's pretty widely available. It works on, you know, a wide variety of quality of specimens as far as cellularity and degeneration. And the other thing that's nice about this assay, it's not probably all that relevant, but it actually, if you can tell you the actual HPV type, so it can tell you, is it 16, is it 18, or what other subtype is it, as long as it's in one of the specific high-risk types that are not the pooled high-risk type.
Yeah, and the thing is, you don't know how relevant it is until you know all the types. So it's a good way to collect data.
Yeah.
Great. There was some mention about platforms. You find one good, better than the other? They're all.
I mean, I think they're all good. You know, Roche has probably a bigger footprint in the whole market, especially with, you know, being approved for primary screening. But I think all of the assays work well. I think one thing that is, I think, important in whatever assay you use, if it has an internal positive control, so something just to say there are enough epithelial cells in the sample, you know, because you don't want to just have a pure cyst fluid come back negative because there was actually no epithelial cells. Hopefully you can correlate that with your cytology findings. So actually one of my favorite specimens for neck cysts are liquid-based, you know, either SurePath or ThinPrep slide and a cell block, because a cell block is still nice to help confirm squamous differentiation in some cases. So I think that's like maybe the best specimen for these types of neck cysts, because you can do a lot of testing on both a liquid or on the cell block.
All right.
And you get good morphology that way. So.
Great. So we answered a lot of the questions here, but we discussed kind of what we do here at CCF. We discussed a little bit of your preference, which seems to be the liquid based, with a ThinPrep slide, or with a slide and a cell block. Any limitations? I mean, we discussed some, but any you want to add to your survey in general?
I mean, I think.
Or anything you would have done different?
I mean, it's hard to say exactly how to have done different. I think there's some of the questions it was, you know, I wasn't sure, you know, were we getting multiple responses from the same lab? You know, we got some answers that were unsure, so I don't know. You know, obviously, ideally, we would know each lab, you know, like the director of that lab telling us exactly what they do and how they do it.
Yeah.
I would have loved to have gotten more info on how different labs did do the validation, because, like I said, there's no guidelines.
Right.
And I've seen different stringent requirements depending on the lab, because they provide their own requirements. You know, CAP has some guidelines. And so I think that's where, you know, I still don't know the best way to validate this. And as far as future directions, I think moving forward towards liquid-based would be ideal for all the reasons I said, but I do think it would be ideal if we had some guidelines on to how should you validate that, what should be the requirements. Because in the end, I do think it's a very similar test to that, what's done in the cervicovaginal samples. So. All
right, well, that's it for us. If you have any questions, please type them in the chat. I meant to say that before the end of the talk, but if you have any questions, please type them in the chat. And I think we have someone handling those questions. Do we have any questions?
Hi, thank you very much for the very nice presentation. No, I don't have any questions in the chat box, but I would like to actually ask a question. So for when you say for the reflex to HPV on your cytology material, is it kind of done the same way that we do reflex for ASCS? So basically you look and then you use the same material, or you aliquot at the beginning of the process? How does that work?
So again, I think that's going to depend on the lab and the way the specimen. So my ideal would be you should probably do whatever the workflow is that you do for your lab for ASCS if you're going to do it on the liquid-based specimens. So if you're doing what, you should do that, just because I think you want to keep the neck cyst testing as similar as you can to the cervicovaginal.
Right.
You know, so by as far as reflex, I mean, just, you know, depending on what your technique is. The other question that we did not address, and I'm not sure if you're getting at this either, but, you know, when should you should it only be positive cases? Should you do it if it's suspicious? You know, should you do it if you have atypical squamous cells? Those types of things. I think those are other questions that we didn't address that are also interesting questions, though.
Right. Very good. So I guess in my view, the way that we used to do for the HPV for ASC is basically the cases would come. So before we even have the cytology made and looked at, every case that would come would get aliquoted. And then based on the need, we would go back and use that aliquot for the HPV testing. So I guess in this setting, I think for the workflow, that would make sense. But as you said, every lab has to decide on that for themselves, because the main thing was that making sure that we have something to run the HPV on if we needed to. So I guess that's interesting. Very good. Thank you very much. I guess maybe a lot of your questions were answered last night, or the people who had questions, and you guys went into very nice detail about it. So I guess it's a compliment if we don't have any other questions.
All right. Well, I'd like to thank Chris for taking time out of his day to go over this. I think he was the right guy for this topic, and it's it's an emerging field, and it definitely is. There definitely will be some future directions in this testing, how to test, what samples to test, and things like that. But it's certainly a new and exciting part of pathology, I think, especially cytopathology. So anyway, Chris, thank you very much, and thank you for having us. This was a lot of fun.
Thank you.
All
It was
right.
very nice. Thank you very much. Have a wonderful day. Thank you. Bye.